I see more people in the room. I think I'm still missing also teams from the countries and others. Maybe we'll give it 1 or 2 more minutes if that's okay with everyone. Okay, so thumbs up. Thanks, Ivalda.
Hi everyone, this is Daniel. I'm here with Patricia just to say hello. And maybe we can get started because the session is being recorded and it will be online, so maybe we can go ahead.
Okay, yeah, that's a good point. Okay, great. Thanks. Hi, welcome everyone. Thank you for joining another session of the SRS webinar series. Today's topic is lessons learned from early phase project implementation. And in today's session, we aim to highlight a bit the practical insights from countries that have already navigated the earliest stages of SRS implementation and to hear about what has worked well, what has been challenging, and what approaches have helped move the rollout of SRS forward and so on. So we'll have two presentations, followed by, as usual, by questions and answer discussions at the end. And as always, we will also share the presenters' slides after the session and the recording. So I would like to start by welcoming our first speaker, which is Dr. Ivalda Masikame, a medical doctor with a PhD in international health and more than 30 years of experience in clinical and public health research, including surveillance and emergency preparedness. Dr. Masikame currently serves as National Director for Surveys and Health Observation at Mozambique's National Public Health Institute and is the principal investigator of the COMSA project in Mozambique. Welcome, Dr. Masikame, and the floor is yours.
Hello, everyone. Good morning, good afternoon. I hope you can hear me.
Yes, loud and clear.
Perfect. So as Patricia said, I will be presenting the experience of implementing COMSA or SiS-COVE, as we call it now, in Mozambique. And I think it was a little bit difficult first to distinct the early phase and where we are right now. So maybe we will see there will be a mix in what I will be presenting, and I see that Agbesi is also online, and he can also support me because he's been working with INS as a point PI as I am for this project. This is just an overview of where and when we started. We started in February 2017 as the countrywide mortality surveillance for action, and we started as a proof of concept. And because it was clear that the country needed this kind of platform to have CRVS because of that data available and representative, we decided that we should recognize this system has from Mozambique. So the country owned a part starting in 2021 the system, and the transition phase started that. So that's where we decided during the transition phase to change the name from COMSA to SiS-COVE. That is a Mozambican name. We had to shift the funding, and we also incorporated other initiatives. So I will start with when the first lesson learned in our definition is that when we think about SRS in our countries, we would need first to decide or to define what is the main goal, what is the main objective of the SRS that we want to implement. And for Mozambique, we definitely were guided by the SDG 3, and we wanted to have a broad goal that is to generate continuous mortality and cause of death data with representativeness not only at the national level but also at the provincial level. As many countries, we wanted to go deeper at the district level, but it was not realistic, at least at the time that we started COMSA. And we also had other goals related to improving the verbal autopsy base because of that. So just to say that at the beginning, we decided that verbal autopsy would be the basic because cause of death determination was imperative for Mozambique. The second lesson that I want to share is the involvement of the main stakeholders. It's important to map what are the main stakeholders that should be involved at the beginning, at the conceptualization phase of the SRS. For Mozambique, we started with the National Statistical Office, or the National Statistical Bureau, that we call it INE, and INS, or the National Public Health Institute, where I work, was part of the definition of the SRS from the beginning, but our role was mainly admin and specific for the verbal autopsy and the connection or the linking with CHAMPS. And we decided at the beginning, because we identified that we had needs, and there were some technical aspects that in country we will not be able to solve. So we decided that at the beginning we needed technical assistance from Johns Hopkins University and the Ministry of Health and the Ministry of Justice, where we do have our CRVS in Mozambique, were part of the process from the beginning. The third lesson is, although we map and we define roles, sometimes we need to adjust the roles. And that's what happened in Mozambique with our SRF, where at some point it was clear that the main role of the SRS should be at the health sector with the National Public Health Institute, but the other institutions or the other stakeholders were still involved, but with more specific roles. And the technical assistance from Johns Hopkins were always needed. The fourth lesson I wanted to share is that it's important to identify or define what is the ideal sampling, the ideal representativeness. As I mentioned, for Mozambique, it was clear that we needed subnational representativeness at the provincial level. That's why our sample size is way bigger than the surveys that we are used to implement in Mozambique and probably in other countries. So this is just to share the comparison with COMSA sampling and sample size with the usual surveys. This is an example of the HIV survey, the FIA. So where we see that we have a bigger sample size and the advantage of having a continuous data collection system that allows us to have subsamples to collect other specific data, especially when we're talking about maternal, neonatal, and child health specific data. The fifth lesson is right at the beginning. It's important to define what is the main data collection and analysis tool. For Mozambique, we decided that the community would be the basis for data collection, that we needed community workers from the community. And at the beginning, we wanted to train existing community workers from the Ministry of Health, but this was not possible at the moment because of the workload of the community workers from the Ministry of Health. So we needed to train new people. We defined it at the beginning that we needed real-time data collection. So we decided that paper would be only for consent forms and when cell phones and tablets would not be available, but the main data collection tools would be cell phones for the community workers and tablets for the verbal and social autopsy. Another big decision that we made right at the beginning that was that we wanted not only to understand the causes of death, but also the social determinants of that. That's why we have what we call VASA, the verbal and social autopsy questionnaires. And we also decided that we will not be using medical doctors to determine the cause of death. We would be using automated methods. As you might know, Mozambique is a low-income country. We have less than 5,000 medical doctors for more than 30 million inhabitants. So it would not be realistic in our context to use medical doctors continuously to determine the cause of death. And we decided that we really needed to explore different automated methods. Another lesson is to consider the IT and the data system infrastructure that will be used at the beginning and think at the future. So what will be if that kind of infrastructure could be considered for interoperability, for innovative solutions. For COMSA, we were successful because we definitely from the beginning used systems that were automated that allowed interoperability with the CRVS system and with from the DHIS2 we decided to develop a specific module and it was allowed with the systems that are in place up to now. The lesson number 7 is about the main outputs. Is important to decide because we could collect a lot of data, but what are the main outputs that cannot be missed during our reports, and that will be the main goals from the SRS or from the system. For Mozambique, the mortality data is definitely the main outputs related to the mortality rates, the cause of death, and the social determinants of death. And understanding the costs at the beginning, this is very important. How much, according to all the methodology defined and all the needs and the goals, how much the SRS will cost in the different phases, because it's important to understand that at the initiation phase, it will be more costly because we are trying to build the system, but then you have the maintenance phase that will be less costly, but there are definitely specific activities that need to be implemented to keep or maintain the quality of the system throughout the implementation. The lesson number 9 is related to funding. So mapping potential SRS fundings is important. As I mentioned at the beginning, for Mozambique, we had different funders, different donors, and it's important to be aware of which donors, which funders has a specific interest in SRS or in cause of death or in mortality. So this is just an example of how we were able to transition from the Gates Foundation to the Global Fund monies, that because we were aware that the MAA a module from the Global Fund GC6, GC7, there is a specific module for civil registration and vital statistics, but definitely there are some restrictions, but it's possible to be funded. At least it was at the time. Lesson number 10, sorry, it's related to data dissemination and data use. It's important to make sure that we collect data that will be disseminated, that will be known by those that need that information, and that will be used. For COMSA in Mozambique, we have a data dissemination plan where we need to ensure that the data is being disseminated at different levels from national to provincial and the community level. Those that are collecting the data also need to understand what they are collecting in order to maintain the quality of the data that they are collecting. And the interaction with the media is also something that we learned that is really, really important for data dissemination. So we had a very good example with the interaction with the radio, newspapers, and even live interviews to share COMSA main data. And we have a successful story where COMSA data is right now being used as one of the main data sources for the next health sector strategic plan, based on the data that we have. It's possible to identify the main interventions, the main priorities for the next 10 years. And we also share COMSA data with international agencies that it's also important for public health evidence-based decision-making at the national and also international level. Lesson number 12 is about leveraging the system, if possible, to implement other public health related initiatives for Mozambique. Especially during the COVID pandemic, we were able to use our platform for rapid assessments related to COVID, related to the impact of the pandemic. And we are using our customers as a
Hi, Ivalda.
Yes.
Can you hear me? I think we lost you a little bit, and now the sound is it's far away.
Just 1 minute.
Yeah, it seems that it has changed the microphone.
Can you hear me now?
Yeah.
Is it better?
Yeah,
No, it's
yes.
very good.
Okay. That's great. Thank you. So I was saying that if possible, it's important to think about how this kind of robust system, robust platform can be leveraged to implement other public health related initiatives such as research or such as rapid surveys. And for Mozambique, we used SRS for mobile phone surveys and to assess the impact of COVID on mortality. And we are right now using COMSA as the basic for what we call integrated disease surveillance. And we also have a very good experience on using COMSA platform to do multiplex survey. And this is one of our latest papers published, which is very, very interesting. And it's being used by our immunization program from the Ministry of Health for future interventions. To summarize, we have, and we call it lessons, but it's important to acknowledge the challenges when we're implementing such systems, but also look at them as opportunities. In general, it's important to look at the financial aspect of implementing SRS, making sure that this kind of systems, surveillance, health system strengthening is a priority for the country. It's important to acknowledge the vertical funding that exists in many situations, and how to navigate this verticalized in silos regarding funding for specific diseases. And on human resources, it's definitely the priority. Without people, there's no SRS. So making sure that there are investments on community workers, especially and the capacity building at all phases of implementing an SRS. Collaboration involving all stakeholders, as I mentioned, is extremely important. And it's important to make sure that involvement it's not only at the beginning. We need to still work together at all phases and exchanging the experience. We had the opportunity to have countries such as Zambia and Nigeria and Mozambique to share our experience with, but we definitely learned a lot from them too. And we are open to receive other countries in Mozambique to see in local what's going on in the field and what's our IT infrastructure, if infrastructure looks like, and sustainability. Leveraging existing health information initiatives is important. As I mentioned, we built our IT, our data system from scratch, but definitely using open sources. But if possible, making sure that we are using existing systems is important, and making sure that the government prioritize SRS not only at the health sector but in other sectors too, because mortality is not only the responsibility of the health sector. So in general, this is what I had to present to you, and this is to share how our SRS, how our COMSA, our SiS-COVE was recognized in 2024 from the International Association of National Public Health Institutes, IAMFI, has the Africa Regional Network recognition of success. And thank you, everyone. As you can see, it's not the National Public Health Institute success, it's everyone's success in Mozambique, and also the stakeholders at the international level. Thank you, everyone, for listening.
Thank you very much, Teribalda. Obrigada for the presentation, for a very clear and insightful presentation. I'm sure the country teams could get a lot of insights and ideas from those early stages of the implementation. I think we would move on to the next speaker now, the next presentation, and then leave the Q&A for afterwards. I see that Professor Anand